Good afternoon, everybody, and thank you all for joining us again for this fourth of a series of ESR Connect webinars. I'm hosting this from Cork in Ireland. It's all being put together in Vienna by our colleagues Dominic and David and Steffi. And today we will be speaking to experts from Norway and Germany about their experiences in managing aspects of this COVID pandemic. For those of you who live in countries that are socially isolated and partly or wholly locked down, which I imagine is probably most of the audience, and for those of you who are missing sports, I'll put this in a slightly sporting context. We have speakers from Berlin today, host of the 2009 World Athletics Championships and many other major athletics events, and from Bergen, much more importantly, host of the 2017 World Cycling Championships, and a beautiful place if you watched those championships. So while we're all somewhat sports deprived at the moment, we can perhaps look back on those events if we remember them while listening to the speakers. Today we're going to deal with a couple of very different topics. The first one will be from Anagha Parkar from Bergen, who will speak to us about structured reporting in CT in COVID-19 patients, in particular the things we ought to be mentioning and the things we need to point out that might indicate a diagnosis or of COVID or another diagnosis. And then following Anagha's talk, we will move to Berlin, where we'll be joined by Dr. Felix Dellinger and Mr. David Gunther from the Charité Hospital, and they're very welcome. They will be speaking about how their department has put in place workflows to protect staff, radiographers and radiologists, and how they've managed through this pandemic. And then we'll also be hearing about the overall German experience during the crisis. Germany as a country seems to have done particularly well in managing this crisis, this pandemic, and there's a lot we can learn from Germany's experience. So I'm going to hand over first to Dr. Anagha Parkar from Bergen, who's going to talk about structured reporting in COVID-19 patients. Anagha, please.
Thank you, Adrian. I'm Anagha Parkar. I'm a general radiologist with a special interest in thoracic imaging. Next slide, please. So in the ESR report that we created last week, which was very well and quickly done, we presented a structured report, which we mean should work as a guideline for radiologists. It can function as a checklist, because when we are dealing with a new diagnosis, which is relatively unknown and we're unsure about what to look for, it's good to have a guideline, and then you can follow these steps step by step. Because the difficult task is when the findings are not typical, can we say it? How certain can we say it? And then how can we convey this uncertainty to referring clinicians? So this is the cutout from our paper, which can be found where you can see in the lowest part with the PDF on the ESR website. And we started with, we suggest that if you do a CT for COVID-19 especially, you don't have to do contrast, and you should have maximum 1 millimeter thickness slices. In France, you have to always put in the radiation dose. In Norway, you don't have to. But after that, you have to look for the typical findings, which are the presence of bilateral diffuse and confluent patchy ground glass opacities with a rounded morphology or crazy pavement patterns, usually in the periphery. Or you can have presence of ground glass opacities with consolidations and linear consolidations. And the next thing that you can have is that you have you don't have any centrilobular nodules, and you don't have any lymphadenopathy, and you don't have pleural effusion. If you have that, then it's probably not likely to be COVID-19. And what we keep forgetting, that we have all these patients, and maybe less than half of them, at least in Norway, only of 1/3 of them at most, or 1/4 of the patients who come in with dyspnea actually have COVID-19. Most people have something else. So we have all these patients who come in with question of COVID-19, and most of them don't have this. Then you can come to a conclusion, but of course, before you do that, you have to look at all the other structures as you always do: the heart, the vasculature, the pleura, the mediastinum. But here we will be focusing on what's important for the diagnosis of COVID-19. Next, please. So these, just to go through, as you've probably seen this before, we have the typical patchy ground glass opacities in the periphery in both lungs. You have the rounded morphology. There is not any subpleural sparing, and it's all patchy in both lungs and in all areas. There's no predilection, either it's upper or lower, it's everywhere. This is a typical pattern. This is also one of the typical pattern where you have crazy paving pattern. That is when you have interlobular septal thickening with ground glass opacities. And some of them are more rounded, but most of them in this patient are in the rear parts, in the posterior parts, mostly confluent. This is again a typical pattern. If you see this, you should say most likely to be a viral pneumonia, could be COVID-19 or corona infection. This is how we say it, at least. This is when it starts getting more difficult. You have patients who are not in the early phase, but in the later days, maybe past day 9 or 10 of the infection, and they start getting linear consolidations, which you have the perilobular configuration. You have these lines in the left lower lung with these stripy consolidations, and then you have one big area of ground glass opacity. We have a combined picture. This is also a picture of COVID-19 infection, and this is when it starts getting complicated, because at one point the ground glass opacities disappear, and maybe you do CT at a time when you only have linear pattern, then it's very difficult to say for sure this is COVID-19 on CT. But if you have a combined mix pattern, then you can still say this is COVID-19. So if you have a patient who has tree in bud pattern or centrilobular nodules, and you see these chronic changes in the lower part of the lung, but this is a patient who has tuberculosis. So if you have this huge subpleural sparing and it's not all the way to the periphery, it's not patchy in both lungs, and it's not confluing, or it's more ground glass, but just small nodules, then it's not COVID-19. And you should then say this is not typical for COVID-19, because one of the things that you often do when you have a diagnosis, everybody just converges on the diagnosis, that one diagnosis, and you forget that there are differentials. So you have to keep an open mind all the time that other patients also are coming to our hospital, and not everybody is going to have corona infection. So this is a patient who came in with the clinical symptoms very reminiscent of corona infection, and she was tested twice. We have in the right lung, you have a small area of ground glass opacity, but the left lung was completely consolidation, a huge big lobar pneumonia. You have this peripheral sparing, and you have also in the lower right lung consolidations, and this was a typical normal pneumonia. So it was very important that we said that this is definitely does not look, and very likely not to be COVID-19, because then they could they can triage her in a different room, not necessarily in the full gear. And they waited, of course, for the 2 days for the test to be negative. They did double tests, and then we could relax. But we should not forget that other patients also are being admitted to the hospital with normal pneumonia. So this is when you should not say this is COVID-19. So in our structural report, we had first the description of the typical findings and what are the ones that mostly rule out COVID-19. We also suggested that you can have a visual assessment of disease extent on CT, and you can either use a scale, which I find is a bit difficult in the clinical sort of workflow where it's quite busy and you're on call and there's phones, beepers going off all the time, to use the scale of 10%, 25%, 25 to 50, and 75%. So we would also say that if you don't have time for that, it's very easy to use the 3 ones: mild, moderate, and extensive. In the mild one, you just have a couple of few spread opacities, ground glass opacities, 3, 4 maybe. In the moderate ones, you have still about 50% of the lung is normal and 50% is visible, and the extensive is more than 50% of the lungs that are affected. So this is a simple rule of thumb to use to give you a disease extent assessment on CT, which is quite easy to use. And I would suggest, if you have a patient, try to give them a help on how expansive or how extended the disease is in both lungs. So our clinicians, and this all depends on which hospital you are in and how pressure the hospital is. And our clinicians, we all often start with, if the patient is not too dyspneic and there's a suspicion of COVID-19 and we haven't got the PCR test yet, positive or negative, we're still waiting, then they always ask, well, can you see something else that is a cause for the dyspnea, which is pneumothorax, pleural effusion, lobar pneumonia? And if not, then we just say that, okay, this is not found, but it still could be a viral pneumonia. And if you do a CT, then they always ask how much of the lungs are affected. Are there consolidations, or are they just ground glass opacities? So these are the two things the clinicians always want, because when the patients have a lot of ground glass opacities and the extent is massive, they can very quickly end up in the ICU, and then they really need to know how badly the lungs are doing. So which statements do we need to include? Of course, I have to say in our hospital, most of our CTs have been done for other causes, usually pulmonary embolism. So they ask, is there a pulmonary embolism? And if that's the question, you have to answer that first, of course, yes or no. And then if there's no other questions and you do suspect COVID-19 based on the findings, you have to convey this with a degree of certainty. Are you really sure? Are you indeterminate? Or is it probably not likely that it's COVID-19? And if the question is acute illness, of course, you don't go around using a lot of time reporting that there's no malignancy or chronic illnesses. That will be irrelevant. You have to stick to the points and answer what the clinicians are asking you to answer. So for me, it's relatively easy when it's typical, and it's relatively easy when it's not typical, because then I know for sure. But this middle ground where you're not sure, where we say it's indeterminate, I try to actually specify if it's probable, possible, or cannot be excluded, which is actually the same as indeterminate. But this is more, I would say 50% of our patients are in this indeterminate group, and the other 50 are either typical findings or not typical findings. So these were my slides. Thank you.
Thank you very much, Anagha. That was really helpful. For those of you who haven't seen it, a few weeks ago, a number of authors from the ESR and the ESTI put together a short paper giving practical advice to readers about diagnosing COVID pneumonia, how to manage it within the department. And Anagha's proposed structured report, which she showed in one of the early slides, was included in that paper. And Anagha, of course, was one of the co-authors. Other co-authors of the paper were experts from Italy and France. And we, of course, previously have interviewed Italian, Spanish, and French experts on earlier episodes of this webinar series. So I would advise any of you who want a little bit of guidance or want a ready reckoner to have beside you in your reporting stations to have a look at that paper. It's available on the ESR website. It would be published in European Radiology, but we made sure that it was available on the website as soon as possible in advance of publication to help people with their day-to-day practice as they work through this crisis. We will have time for more questions at the end, but I'm going to move on to our second pair of speakers now from the Charité Hospital in Berlin, Dr. Felix Döllinger and Mr. David Günther, and you're very welcome. I'll hand over to you.
Hello. Thank you very much for that kind introduction. So today's topic is collaboration is key, and because of that, it's a pleasure to introduce to you David Günther. He's one of my favorite and one of our best radiographers. His specialty is sophisticated CT imaging, for example, cardiac imaging, and he just told me that he is working for Charité University Medicine for nearly 13 years right now.
Next to me, it's Felix Döllinger. He works in Charité for nearly 10 years, and he is an expert for lung imaging. And together we will show you our slides.
Yeah. I think it's a great idea by the people who organize ESR Connect to invite a radiographer today, and we will start directly. Our part is divided into two chapters. At first, we're talking about measures taken at Charité University Medicine, which is the biggest university hospital in the whole of Germany. And afterwards, I was asked to say some words about the typical German experience we made through the last 2 months. I will start with measures taken by the administration of Charité University Hospital. And maybe most important there, at the very beginning, and that was the first week of March already, communication infrastructure was created. So a pandemic management team with selected experts from different fields was introduced, and all departments had to nominate a representative for this pandemic management team. This pandemic management team sends out daily updates in the form of video conferences or through our dedicated intranet page. It's impossible for the staff right now to get to miss this page. It directly pops up on every computer you start, and there you can see very important information and official documents. For example, here, this is about protecting staff at risk, and everybody's able to check this online. Very early measures on patient management were taken. So most of the elective procedures were cancelled or postponed, and most of the people working for Charité got a ban on vacations and official trips to ensure that there's enough personnel at Berlin at work. A dedicated COVID-19 emergency unit was established, and dedicated wards for COVID-19 patients were locked off the rest of the buildings and the rest of the hospital. Our colleagues from anesthesiology did great efforts in expanding the intensive care capacity by nearly 50%. And one thing I want to show you is the so-called cough app, which is thought to help patients to find their way if they should visit a general practitioner, if they should visit a hospital, or if they just stay at home and stay calm. So you can see here it is available through your mobile device, or if you visit the web page, and then there's about 15 very easy questions you click through yourself, and afterwards this app gives them proposition what you should do. Of course, and this is mainly from the experience colleagues from China and especially from Italy shared with us, protection of staff is vital. And so there has been instruction on protective gear. Protective gear was rationed, and from the very start, from the last week of February, PCR testing of staff was available. So all staff with unprotected contact to COVID-19 patients and staff returning from travels, they underwent PCR tests. And there is opportunity for all staff members to vaccinate for germs like influenza or pneumococci to get safe as far as possible. Through the whole of the hospital, we have harsh contact restrictions, so no more visitors are allowed to any wards, and most of the entrances to the hospital area are closed right now. So this is one of the 3 hospitals the Charité consists of, and here you can see that of 11 entrances, only 3 are kept open, and the ones that are still open are guarded by security, and they will check to show your ID if you want to enter the hospital. But there are also other contact restrictions. So very soon, most of the canteens and cafeterias were shut down. So most of the Charité staff brings their own lunch right now. This photo is really something special because you can see in the upper right, it's 1:20 on the normal working day, and here normally there should be a crowded place, everybody getting something to eat and drink for lunch, and this is absolutely abandoned. Now I will hand over to David, who will continue with the specific measures taken by the Department of Radiology.
So, Now I show you the specific measures taken by our department. We have a daily telephone conference with the head of the department, which is the ESR past president Bernd Hamm. Then we have a nomination of a chief coordinator for the pandemic, which is Felix, who sits next to me. Then we try to brief all the staff, like radiographers, nurses, the doctors, everyone, by email at least twice a week. And the provision of information and scientific publications. The patient management is very important. In the teaching, we use pseudonymized cases, and the teaching residents the basics of equipment operation. Here at the picture, you see a radiographer who shows the residents how to make a chest CT, and there he uses a phantom. In our department, we include also technologists of the nuclear medicine and the pediatric radiology, and we show them to make a chest X-ray and bedside chest X-ray and how to make a CT of the chest, that they can help us in case of emergency. Then it's important that we have the technical infrastructure for home office work. Sometimes our radiologists, the doctors, can do something at home. For us, for the radiographers, it's not so easy to make something at home. But for the doctors, it's sometimes possible. And we recruit student assistants for help, especially the radiographers. That's a very good thing. Then I think one of the most important parts is the protection of our staff. We established a central storage and distribution of protective gear. We try to order a larger amount of protective gear and disinfectants, and information on psychological counseling services was provided. In our department, there are hard contact restrictions. Our reception counters are closed. The patients only can register by phone. We examined only planned patients, and we limited the access in the waiting areas. Here you see a picture of our reception counter. Here it's a warning that they don't go into the room. They have to call this number to register, and here they have to keep the distance, and they disinfect the hands. The next picture shows a waiting area. We placed at every second chair a paper that the patients don't sit there, that we keep the distance here again. And this is the waiting area of our computer tomography. And here you see the papers again to keep the distance in every time. Isolated patients, it's not allowed to move alone through our hospital. It's very important that the COVID isolated patients are every time transported, most times by a transporter. You see them here. He wears the personal protection equipment, and I think 90% transporter accompanied the isolated patient. Sometimes it will do a radiographer or a nurse or a doctor from the ward, but in every time accompanied with the personal protection equipment. There are hard restrictions for the staff in the control room. It's only one radiographer in the control room. Maybe if you see a picture here, you see the one radiographer who works with the patient. He wears the whole personal protection equipment with the gloves or the face mask and the glasses. And the other of the two radiographers who works together is in the control room, makes the examination and wears only a simple face mask. If there is a patient from the intensive care unit, then it's allowed for the doctor to come without in protection equipment in the control room and to see the patient. Yeah, and here it's written, and it's very important for us that the team which comes with a patient from the intensive care unit waits during the examination on the corridor. Yeah, they don't come into the control room. Here it's shown in the picture. In the room, there's one radiographer with the personal protection equipment, and there are a doctor and somebody else from the intensive care unit. Yeah, and they prepare the examination. And in the control room, there's the other radiographer who waits there and makes the examination. There are some other contact restrictions. There actually there are no clinical rounds. We have fewer case demonstrations, and there are only spatial separations of tumor boards. That's that not so many people are in one room, yeah, to keep the distance. That's our doctors have, if it's possible, they make home office days for our radiographers. It's not possible, and the exclusion of doctoral candidates, for example. We have dedicated scanners, yeah, or rooms for the COVID patients. For example, we prepared one CT or one MRI, especially for COVID patients. There is the room is nearly empty. There are only necessary tools in the room. Yeah, then it's definition of the CT indication. It's very important for us. Maybe, for example, the ultrasound is for all isolate patients only bedside. Yeah, and we have created a separate X-ray unit in the COVID emergency unit. In this picture, you will see the entrance to the COVID first aid, and we have another picture. Here you see a potentially COVID patient and one radiographer, again with the whole personal protection equipment, who makes an X-ray chest. So this last part I will give back to Felix.
Yeah, thank you very much, David. Again, we're talking about the protection of staff, and we have a very good Institute of Hygiene at Charité and perform simulation trainings in cooperation with the doctors and the nurses there, which is very important. So they showed us the few things that we were doing wrong all the time. And after that, we put down some hygiene guidelines for each modality, because of course they have to be specialized, and it's not that one size fits all. I will give two examples right here. So this is for the Röntgen unit. It's about X-rays and how the people will have to deal with it. So there's one dedicated place where the X-ray examinations can take place, and here is a guideline how to indicate and how to perform CT in patients with confirmed or suspicion of COVID-19. And now we're getting to the last part of today's talk, and of course Adrian asked about the German experience, and it is a delicate question because now I'm showing the following slides just show my own personal opinion. They are not related to ESR or Charité. I'm sure that many of you also take a look at Johns Hopkins Statistics Resource Center from time to time, and here I highlighted the numbers for Germany 2 days ago. Right now we have more than 130,000 patients with a confirmed coronavirus infection and more than 3,000 deaths of these people. But compared to the rest of the world, the German case fatality ratio is very low at 2.4%, and yesterday night it was only 2.5%, so it's very slowly increasing. But we have to talk what the reason for that statistics is, and be sure I'm not telling you that we are doing better than anybody else in Europe. And we are very humble at Germany, knowing that this is just a detort. It's just a statistic at one time. And we will talk about that, what seems to be special about Germany in these days. And I didn't have that feeling myself, but like 10 days ago, a good friend from Michigan, Detroit, Michigan, sent me this New York Times article. And here I want to highlight the following sentences. There has been talk of a German anomaly. Why is your death rate so low? This was asked a very famous virologist from the University Hospital of Bonn. And at least the authors of this article conclude there are several answers, experts say, a mix of statistical distortions and very real differences in how the country has taken on the epidemic. And I want to share the following with you. Reason number one, why the fatality rate in Germany is so low until now. It's a temporal changes. Here we have that statistic from Johns Hopkins, and you see that Germany is 2 weeks behind Italy. So the horrible situation at northern Italy especially was helpful for us, and we know how lucky we are having this experience from our colleagues in Italy. We knew that COVID really had an impact, and the coronavirus pandemic had to be taken very serious from the very start. The first larger group of German patients were young and healthy skiers and winter sports people returning from the Austrian and Italian Alps. And so we knew from the very start that also young and healthy people can suffer from coronavirus infection. And we had 2 more weeks than, for example, Italy had to prepare for that situation. Already on March 11th, Angela Merkel, the Chancellor of Germany, had her first official statement on coronavirus. And just 10 days later, already social distancing was set to law, and groups of more than 2 people were not allowed anymore. Second reason. This picture here, the people are waiting for the Corona test center, and I think this is the most important of all the reasons I will present today. There's excessive testing in Germany since more than 6 weeks right now. Already in mid of January, at our hospital here, Charité University Medicine, a team developed a test for coronavirus, and the widespread of this testing started very early. Right now in Germany, we are able to perform more than 300,000 tests per week. And from the very start, patients never had to pay for these tests, which is very important. Reason number 3 is tracking. And tracking is something we learned from South Korea and how the Koreans dealt with the corona crisis. There is a working system of local health authorities called the Gesundheitsamt and public health officers, the Amtsärzte. and they are tracking down every case identified to be infected with coronavirus. And this is one example I want to share with you. On January 28th, near Munich in Bavaria, the first German case of coronavirus infection was identified. And within 2 days, the local health authorities were able to track the route of the infection, which was a car parts company with factories in the Wuhan area in China. And all contacts, more than 200 people, were quarantined immediately. And the company was pushed to shut all sites in China and Bavaria at once. And so this was just a minor outbreak. And leading over to reason number 4. This is taken from open source project statista.org, and here you see how many critical care beds were available in 2009 to 2012. So you see there's large differences between different countries, and now this statistic is more actual because it's 2017 to 2020 numbers. And here you see Germany even increased the number of ICU beds per 100,000 with 34 at the beginning of the crisis, and right now it's 50 intensive care beds per 100,000 inhabitants. And this really is a large difference between different countries. So in a strong public healthcare system in Germany, nearly everybody has health insurance, and we were able to increase from 28,000 ICU beds to more than 40,000 ICU beds right now. And so this gives us the lucky situation to avoid triage situations, keeping emergency and oncology procedures possible until now. And we even were able to accept, of course, the number was very low, but we were able to accept some patients from France and Italy for intensive care in German hospitals. And now getting to the last reason, number 5, which is the trust in government in Germany. So under Merkel's government, communication was clear, calm, and regularly. The German press often writes that you feel that Angela Merkel, the German chancellor, is a scientist herself. She's a physicist, and people felt that decision-making in the beginning of the crisis was rational and led by scientific results. So social distancing measures began very early and are supported by the vast majority of the society. This is screenshots from my own smartphone, and here you see this is the Corona info channel of the Ministry of Health, and I get some news there every day. So they are using social media channels and modern ways of communication to reach the people at Germany. And of course, this is with a smile on my face, my fellow countrymen, they love organization. And if you walk around, even in Berlin, you won't find many people who are not keeping to the contact restrictions. This is the last picture I want to share today. It is made by my own dad, showing my mom in front with a daily chat with the neighbors, and everybody keeps at least 3 meters distance and nobody's getting close to each other. And these are situations you see everywhere in the country right now. The people are really trying to do their best to keep the contact restrictions. And so let me conclude. Possible reasons for the low fatality rate in Germany. We had very valuable experiences from China and especially Italy, and Germany had 2 more weeks for preparation for the crisis situation. Then there's a strong public health system with plenty of ICU beds, and there's trust in government, and public is following the instructions until now. And but we are sure, and we know that that all that is distorted statistics, and the German fatality rate will definitely increase during the next weeks and months, because right now the average patient in Germany is younger than in other countries, and the excessive testing, performing more than 300,000 tests per week, of course, catches many people with no or few symptoms. So I hope I could make my point that this low fatality rate in Germany is not the truth, and it is very factors getting into it, very many factors. And I guess it's time to talk right now. Please send your questions towards all of the speakers today.
Thank you very much, David and Felix, for that fascinating presentation. I hope you're not really right in what you say at the end, that the German fatality rate will rise. You've had great success in managing this pandemic so far, as have a number of other countries, including Norway. There's a lot that we can all learn from that. Some of the factors that you've outlined can't be fixed quickly, particularly those that relate to overall investment over a long period of time in healthcare systems, but some of them can be fixed pretty rapidly, and among those are the extensive testing and contact tracing that you've described. Most countries should be doing more of both of those, I think, and I think they are the key to isolating active cases and limiting the amount of spread. We've been having lots of questions coming in, and I'd like to put some of those to both our speakers. Just again, to apologize to those of you who lost signal about halfway through this broadcast. Unfortunately, the Vimeo server crashed. It was beyond our control, but we've been back online. We will put together a full recorded version of this broadcast, which will be available on the ESR website tomorrow. So if you didn't catch all of it, or if you haven't been able to stay with us, I hope you'll be able to see the recorded version afterwards. But I'm hoping that some of you have been able to stay with us and are catching this live. So can I turn to Anagha first with a couple of practical questions? Firstly, one of our questioners asked about gender differences in COVID pneumonia. Are you seeing major gender differences?
Yes. In Norway, most of the patients are younger, and our average age in Norway is around 45, 46 years old. And it's mainly men compared to women, for sure.
And Felix, is the experience the same in Germany? Is it more a male disease?
Yes, I think it is quite a question, quite a lesson we learned from China already. Male sex is predominant, and I also have the feeling, we discussed this earlier, the people who really get severe pneumonias and get on the ICU wards, many of them have malignant disease, many of them have diabetes, and maybe the worst cases I have seen within the last 4 weeks are people with obesity and metabolic syndrome. They really tend to develop horrible pneumonias.
Thank you. Anagha, can I go back to you with the next question, please? Somebody asked us, what does this look like? What does COVID pneumonia look like in patients with extensive emphysema, whose underlying lung appearances are very abnormal to begin with?
Well, I have to say most of our patients have had normal lungs to begin with, the ones with the severe disease. We've had one patient with COPD to begin with, and this patient had perilobular consolidations and stripy consolidations and just a little bit of ground glass apically when the CT was done. We only did one CT. So I think what it looks like depends on the extent of the COPD. If all you've got left is bulla and some fibrous tissue in between, then that is what will be affected first, I guess. But in our patient, we only had one big patient with then that was the perilobular, the stripy linear consolidations. That was the predominant pattern.
Okay, would it be reasonable to say that a lot of the severely ill people are mounting a very strong cytokine surge, and that it's the inflammatory response to the coronavirus infection that's causing a lot of the respiratory difficulties, and that inflammatory response may perhaps not be quite as aggressive in those with long-standing chronic pulmonary disease?
That sounds logical for me, because in our as far as we've seen, most of the CT patients have been a little bit younger and have had good lungs. And the one patient who has really bad lungs to begin with has ended up with super infection with a normal pneumonia in addition to COVID-19 infection. So the patients who've had extensive ground glass opacities had good lungs. And I think, as you say, it's probably the immune response, which is the reason for all this ground glass and not actually the illness itself. So I think it's good to have not too much immunity to begin with. It looks like it, but I don't have any numbers or statistics to do that, support that yet from our hospital.
Okay, thank you. One other question that I want to put to you first, Anagha, that relates to the very elegant descriptions you gave us earlier of the typical findings. What's the probability of somebody having COVID pneumonia if CT shows only a single unilateral area of peripheral ground glass change?
Probability, I haven't seen a paper on that, but what I do know that we have had the cases, we have had 2 cases with just one. The patient came in with high fever and had no CRP, or not close to normal CRP. And the question was, could this be COVID-19? And we had both patients just had one really small ground glass opacity. And I said, well, I think we cannot exclude COVID-19. And 48 hours later, the patients had positive PCR tests. So I would say in this setting, in the current setting, at least in Norway, we have been told that the influenza season is over. So any patient comes in with clinical symptoms of viral pneumonia with high fever, dyspnea, and no CRP or no lab like a normal pneumonia, and you see ground glass, I would not hesitate to report this as a possible COVID-19.
Possible rather than probable.
I would be probable. I would have bilateral patchy, but if I only have a single one, I would say possible.
Okay, thank you.
But I would not rule it out because, yeah.
Yeah, thank you. Felix, I'll come back to you with a question I've just seen pop up. How many patients undergo chest CT when chest X-rays show classic or probable COVID-19 and the patient has a positive PCR test?
Learn from China, most of our patients do not get chest X-ray anymore. We have a very loose strategy in indicating CT imaging, and in patients where the physicians at the emergency unit are sure this is COVID-19, maybe there's no imaging at all. They get into a bed on a COVID-19 special ward, and they get the PCR check. And if they are positive, they will stay there. And if they are positive and they don't have much symptoms, they are sent home. We do not perform too many chest X-rays. It's most likely if the intensive care unit, if some new material is put in, or in the emergency ward, in case our doctors there suspect a pneumothorax or a community-acquired pneumonia, a classical pneumonia. And then these cases, of course, chest X-ray is worthwhile. But in most cases where COVID-19 is the diagnosis or the major suspicion, we perform a low-dose chest X-ray directly.
Thank you. Your mention of a low-dose chest X-ray there brings me to the next question. It's one that came in from Saudi Arabia. And it basically asks about the radiation protection implications of our COVID-19 imaging strategies, because it seems to me that we're relaxing our vigilance a little bit in terms of doing more CT than we would ordinarily do. Now, of course, most modern CTs strive to keep the dose as low as possible, but would you agree that for this emergency, we're relaxing just a little bit in terms of radiation protection maintenance in order to choose the single best test for the best bang for the buck, if you like, for the patient? Anagha, do you have a comment on that?
Yes, for sure we are relaxing, because if you miss a patient who has extensive ground glass opacities which are not visible on chest X-ray, and the patient goes critically to the ICU and dies, then you have not given them a right chance to get the right treatment early enough. Because you want to stop the patient developing ARDS, you want to don't put them on fluid restriction, you want to stop them developing drowning in their own lungs. So we have to, I think it's better to do one CT too much than one CT too little. And also it is possible to optimize your CT protocol to really be as low as possible. The problem is, of course, in patients who are obese, they get a larger radiation dose regardless, even if it's a CT or a chest X-ray. But otherwise, we really we are using a lot of iterative techniques to get the quality as good as possible and the radiation as low as possible. So I think it's worth it. And if you're worried about radiation, you can consider going to a lower kV and using a higher amount of iterative technique on your machine.
Thank you. That's very helpful. David, could I ask you a question? So I beg your pardon, Felix, did you want to come in there?
No problem. Yes, we derived our COVID CT protocols from the pediatric protocols, and so we are performing chest X-ray, chest CTs, and in adult patients now at doses we never did before. So just to give one number to the hand, we tend to have less than 10 milligray per centimeter DLP in most of the studies. And it really, we just want to rule out, is there consolidation, is there ground glass, is there large amount of fluid, and is there maybe a pneumothorax. We are nearly not able to say anything towards the mediastinum, heart, upper abdominal quadrants. It's just focused on lung parenchyma and airways. And I think it's a very good solution to perform CT instead of X-ray in this question.
Perhaps the one downside of CT leads to the next question, which is one I want to put to David in particular. This is a question that has come in from the United Arab Emirates. I work in a COVID hospital where only positive patients are treated. Should we have a downtime for CT between patients since all of them are positive, or is just a wipe down sufficient? That's a tricky one, because I think there are a few of us who only deal with COVID patients.
I think it's important that there is some time between the patients, because here it's so that we disinfect the computer tomograph, and the disinfection needs 15 minutes to dry. Yeah? And this time is very important that the virus is away. Yeah? As I think it's important that there is time between for disinfection after every patient.
Maybe to add,
that's very helpful.
Yeah, we do not only do this in patients with coronavirus infection or suspicion. In our large machines, CT and MRI, we do total disinfection with 15 minutes waiting time after that for between every patient, with a rationale that of course, if a patient is tested positive for coronavirus, the patient before can have coronavirus and pneumococci or influenza or whatever. And of course, we want to keep away the second gem from the next patient. So as David has told earlier, it is lots of work for our radiographers right now, because they perform a full disinfection of the whole room and machine after each single patient.
Which has implications in terms of throughput of patients if you have limited CT resources. And I think that's something that many of us are now facing. We're going to have to wind up in a few minutes, but there are still a couple of other questions I want to get to briefly. One asks, are you finding in Germany, and I think this would also apply to Norway, an increasing frequency of thromboembolic disease, seizures, mesenteric ischemia associated with COVID? I know in an earlier episode we discussed the increased frequency of pulmonary emboli that have been found in Paris and Barcelona in patients who have pulmonary embolic disease. And it seems that there may be some sort of thromboembolic or vasculitic element of this disease. Anagha, would you have any comments on that?
Well, it's a combination. We have had an increase of patients with abdominal problems. And what we are now having introduced just last week, just before Easter, that if a patient is admitted with abdominal issues and has high fever, and the patient is going to do a CT of the abdomen, we automatically add a CT thorax. Because we've had quite a few patients who've had we've admitted with abdominal problems, not with dyspnea. We've had a couple of patients actually who were admitted with who came in as stroke patients, and on the CT, when we do the CT of the angiogram and we have the carotids, we have a part of the lungs with them, and we saw some changes in the lungs, so we then added a CT, and this patient had a corona infection and was admitted with seizures. So we do see that the picture is changing. 1 month ago, we were just talking about lungs. Now we're including abdominal symptoms, we're including neurological symptoms. And I think for everybody who's getting more and more patients, we see slightly different picture. And we just have to be aware that if there's high fever involved at the moment, just think about coronavirus as well. As for embolic disease, we haven't actually had an increase. So I don't know. It's different than in France, like we heard last week, for the last session. They have a lot of embolic patients. We don't have that many embolic patients actually, but a lot of people with abdominal and also some with neurological, which is a surprise.
Thank you. Felix and David, have you anything to add to that?
Yeah, from my point of view, Anagha made a very important point. It's a patient with a neurological disorder. So patients coming with suspicion of stroke or with coma, we started to perform a low-dose chest CT for those patients like 6 weeks ago. And from my personal feeling, we have not statistics right now, but my personal feeling is that in every fourth or even third patient with a neurological disorder, we have findings that could go with COVID-19. So most of these patients come from retirement homes, and some of them, they have a stroke-like presentation. And when we perform chest CT, we have to admit maybe this is with or even triggered by COVID-19. And just a couple of days ago, I learned that COVID-19 can elevate troponin. And that is also really important because right now, in patients with acute coronary syndrome, we would not have performed chest CT earlier. Most of these patients go to the heart catheter lab directly. But right now, in some of those patients, we perform chest CT. And also, I had the first findings of COVID-19 typical lung changes in these patients.
Thank you. I think that's been everybody's experience. We've had a few similar cases of patients presenting with very typical cardiac presentations who have actually proven to have had normal coronary angiography, but were then diagnosed as having COVID disease. So this is not an uncommon finding. We're going to have to wind up now, just very briefly to deal with two other things that came in on the questions. One is somebody asked about whether an AI tool would be helpful in both making the diagnosis and quantifying the amount of lung disease that is present in a patient with COVID-19. And I think quickly the answer to that is that if this goes on for 6 or 9 or 12 months more, such tools will be available to us. And I have seen a couple of very preliminary publications from China suggesting the use of AI. but it's all happened so quickly that the time for developing and training and rolling out such tools really hasn't been there yet. And then the last thing I just wanted to deal with was that somebody asked again if we could display the link to the joint ESR-ESTI paper. I can tell you it's on the myesr.org website. If you go to the main website, one of the first things that will come up is COVID-19 resources. And if you click on that tab, you'll find a direct link to the paper, which can be downloaded. So that should be available to all of you. Finally, to tell you all again that for those of you whose viewing was interrupted by the server crash, we will put a stitched together full version of this, this interview on the ESR Connect website by tomorrow, without the gap in the middle. And I thank you all for staying with us for a little longer than we had originally planned. And finally, I'd like to thank our speakers today, Anagha Parkar from Bergen, Felix Stillinger and David Gunther from Berlin. It's been a pleasure having you all on the show and telling us about your experiences, and it's been extremely helpful. So thank you all very much. Goodbye.